So, good morning and welcome to Recap 2024. And in this section, we are going to review top research articles published in 2024 with an intention to break it down for clinicians. And so here we have selected some topics and articles that we think that are relevant for clinical practice and also would be useful for curious and budding minds. So I'm Dr. Rishikesh Behere, Medical Director and Consultant Psychiatrist at Manoshanti Pune. And I have with me Dr. Shalaka Chatorikar. Welcome, Shalaka.
Thank you so much, sir. Happy to be here. So, we've got some interesting studies lined up for all of you today. So, let's jump right into our first topic. That will be semaglutide in psychiatric disorders. So, semaglutide, like we know, is primarily used for managing diabetes and obesity for weight reduction. But recent studies suggested that there are potential psychiatric benefits to it as well. Now, considering that most of our psychotropic medications have the side effect of weight gain, this drug could very well be a game changer. So, there was a systematic review done, including 374 subjects across 6 studies, that reviewed GLP-1 receptor agonists for psychotropic induced weight gain. The results: the average weight loss was between 3 to 5.3 kilograms, which is quite a significant weight reduction. This indicates significant use of GLP-1 receptor agonists like semaglutide for us psychiatrists.
Okay, so that's interesting because we have heard of semaglutide use in weight reduction, and we also know that psychotropic weight gain is a significant problem. And so, if semaglutide is also effective in psychotropic weight gain, I think that would be something which is going to come up in our clinical practice going forward because we already hear getting a lot of requests from patients asking us about this drug. So that's very interesting. Right. So, but I've also heard that there are some safety concerns about semaglutide. Recently, I saw that there was a FDA warning for thyroid medullary cancers. Do you know anything about that?
Right. So the drug does have a black box warning. It says that there is a risk of thyroid medullary cancer, which is proven in rodents and still under study in humans. But there have been more studies done recently in 2024 itself, which have shown that the risk was not very significant. Moreover, there is preliminary data that says that semaglutide might even be protective for certain obesity-induced cancers like colorectal cancer, pancreatic cancer, etc. So probably, weighing out the risk and benefits, I think it sort of leans a little more towards the benefits of this drug.
Right. Yeah. I mean, I think more observation is needed and probably more data from post-marketing surveillance will tell us. Right. But what about psychiatric safety? I mean, there were also some concerns of suicidal ideation and with semaglutide. So I see a study here. Can you tell us more about this?
Right. So this was a study that explored the psychiatric safety of semaglutide in overweight and obese individuals without any major psychopathology. So we have good news here because it didn't find that there was any significant increase in depressive symptoms or suicidal ideations, thus further encouraging us to use this drug far and wide.
Right. So that again, that's heartening to know that. And I think this study has almost 3,000 subjects. So I think that's quite a good number for observation. And this is from almost 5 trials and without any significant increase in depression. So that's good to know. So it seems to be safe psychiatrically and also has implications for psychotropic weight gain. But what about, does it have any implications directly in psychiatric disorders in its treatment?
So there, interestingly enough, is some really promising real world data focusing on Alzheimer's dementia. So they found that in patients with type 2 diabetes who were on semaglutide, that reduced the risk of Alzheimer's by up to 67%, right? And there's also a new trial called the EVOKE trial, which the protocol of which has been registered already. So hopefully we'll have more evidence base by recap 2025.
Okay, that's great to know. So you're already collecting studies for next year's recap. So that's great. So that this is interesting that besides I mean, because people with diabetes have an increased risk for dementia going forward, and if semaglutide use is going to reduce risk of dementia. I think that's again a very significant observation. Yeah, but as you rightly said, that we need to wait for the results from the randomized controlled trials. Yeah. Any other disorders where this has been found to be useful?
Right, sir. So there is more data. It seems that semaglutide showed promising results in reducing alcohol cravings in adult with alcohol use disorder. So even though this RCT has only 48 participants, it still sort of points towards a new treatment avenue for alcohol use disorders. So we see that there is reduced alcohol drinks on drinking days, reduced weekly cravings, as well as a significant reduction in nicotine use. So yes, more than one use for this drug.
Right. So semaglutide seems to be like a Ramban. So it is one drug and with multiple applications and without side effects. So that's what we all look forward to. So yeah, I mean, so let's see how it pans out in the coming years. Right. So moving on now from semaglutide. So let's look at what's new in the treatment of depression. So treatment-resistant depression is something that we all face clinically, and we have about various trials such as uh, the trials which look at the augmentation and switching strategies for treatment-resistant depression. So this was one study that I came across, which looked at now the newer treatment modality of RTMS versus augmentation and versus switch in treatment-resistant depression. So this was a trial called as the Ascertain TRD trial done in over 278 patients. Again, this was a real-world study. So here it was either an RTMS versus augmentation with aripiprazole versus switch to venlafaxine following SSRI non-response. So interestingly, what this study shows us is that RTMS use seems to be better than augmentation with aripiprazole. And both RTMS use and augmentation were better than switch. So contrary to conventional teaching, the augmentation with aripiprazole and RTMS seems to be newer strategies. And one thing that this study tells us is that probably RTMS can be used much earlier in the course of the illness. So that I think is an evidence that supports much wider application for RTMS in depression.
Right. So basically, it's not that we have to wait and exhaust all other options that we have and then sort of move to these neuromodulation techniques. We can actually consider introducing RTMS much earlier into our treatment plan. So that's actually quite insightful, sir, isn't it? Now, did this study also mention any side effects specifically in the RTMS group?
This particular study did not find any significant adverse effects of RTMS, and RTMS, as we know, is already a safe and effective technique which has been proven in multiple RCTs. So compared to, and also increasingly, I mean, in people who are concerned about side effects of medication or whom medication may be contraindicated. So RTMS, use of RTMS early in the course of illness, that seems to be quite promising.
Right, absolutely. Now, just moving on to the functioning of RTMS. So, what we know or what we've been taught is that it modulates the cortical excitability. The cortical circuits is where RTMS targets. But is it true that it's only at the surface level, or is there at all some evidence of RTMS being useful or being applicable to deeper structures in the brain?
Yeah, so I think that's a very interesting question, and I have just a study for you. So this next study that I came across was evidence of neural effects of RTMS. So in this study, around 22 patients, neurosurgical patients who were transplanted electrodes for intracranial EEG, were given a single pulse of RTMS stimulation to measure the cortical evoked potentials. So what the study found is that that a single pulse of surface TMS, it produced cortical evoked potentials not only in the left DLPFC, which was the site of stimulation, but also in downstream in the anterior cingulate cortex as deep into the insula. So as opposed to conventional teaching that that the TMS is a very surface-based treatment and its penetration is up to 2 centimeters into the cortical surface, what the study found is that that the neural activity is stimulated even much deeper in the circuits which are functionally connected to the DLPFC. I think this is a kind of an unequivocal evidence that TMS directly modulates neural activity in humans, and it provides a very objective measure that TMS really does induce changes in neural activity.
Right, so there's so much more to RTMS than what just meets the eye. And I think this study has sort of opened so many avenues for deeper research into RTMS, pun intended. Now, we're always speaking about biological therapies and paying an ode to the biopsychosocial model. Were there any updates on the psychological therapies and depression last year, sir?
Yeah, so there's another interesting review that appeared last year, which reviewed 5 decades of psychotherapy research in depression. So this particular meta-analysis looked at studies on psychotherapy in depression, which have appeared in the last 5 decades. So over 50 years, they identified around 562 studies, which involved 60,000 patients. So primarily what they found is that with time, the number of studies on CBT is going on increasing. And in their meta-analysis, they found that in general, CBT had higher effect sizes than interpersonal therapy or supportive therapy or psychodynamic therapy or any other therapy which has been conventionally used in depression. And interestingly, there were some other observations. So one was that the effect sizes were usually higher in adults than in children. Okay, because conventionally we see that in children psychotherapy is usually the mode of treatment, and medication seem in most guidelines comes secondary. Okay, but however, the effect sizes were much smaller in children than in adults with psychotherapy. Another interesting thing that they found is that even though it's been 5 decades of research, usually most of the studies were of poor quality on psychotherapy. And so among the CBT studies, which were relatively of a better quality, the effect sizes were smaller than when you pool all the studies together. Uh, as a conclusion, the authors say that even after 5 decades of research, the number of high quality studies is still very low, and so we really need to work on improving the quality of studies of psychotherapy.
Right, absolutely. So 50 years in, and we're still saying that we need more research, right? So the research gap just seems to sort of continue for psychotherapeutic
Yeah,
management.
it never seems enough.
Right. So now speaking about research gap and about exploring new avenues in management, let's talk about newer treatments that have emerged last year for management of acute psychosis and schizophrenia. So a new molecule has been introduced called xanomeline trospium. It is a muscarinic receptor targeting antipsychotic. So it's an M1, M4 central agonist and a peripheral antagonist. What is unique about this molecule that it has virtually no D2 action. So it spares us all the EPS, tremors, rigidity, all of that hassle. So there is this RCT done in 256 subjects with acute psychosis, and this showed significant symptom reduction without the usual side effects of EPS, weight gain, sedation, or even hyperprolactinemia.
Right. That's interesting. I mean, we are always in the search for newer molecular targets for in treatment of psychosis, given the multiple side effects with second generation as well as first generation psychotropics. So this seems to be again a promising, interesting molecule which has a totally different mechanism of action and a non-dopamine kind of an action, and without EPS, weight gain, or hyperprolactinemia. So
Right. So no
yeah.
no excessive baggage whatsoever.
Yeah, the only
Now,
one concern would be that this study shows a 30% reduction in panicis. What it means translates into like clinically, how does it translate into that? Something that probably more evidence is required.
right. I think it's also the lesser sample size and the fact that they have done an intent to treat analysis. So they have just kind of taken the subjects in whatever stage of acute psychosis that was brought to them. So definitely more studies required to sort of reach a more amenable 50% reduction in panic scores, the thing that we say remission means. Sorry,
Right,
response means, right?
right. Yeah, so this was about acute psychosis. Is there anything that's come up in the last year which talks about long-term maintenance in schizophrenia?
Yes, so for long-term maintenance, we have the paliperidone palmitate 6 monthly injectable depot, arguably my favorite study of all of them. So 3 years data showed that over 95% of patients remained relapse-free uh, and stable throughout this entire time. The adverse effect profile is also very favorable, nothing very different from that seen in the 1 monthly and 3 monthly depot preparations. So very promising going ahead for maintenance treatment in acute psychosis, schizophrenia, and perhaps even bipolar disorder going ahead.
Right. Yeah, I mean, I think 6 monthly depot injection would be a boon to a lot of patients, and especially also for caregivers in terms of monitoring treatment. Right. And also I can see, I mean, there were some adverse effects. 50% of them had adverse effects, but it doesn't seem to be very much different from what you would otherwise expect with depot injections. Right.
Right. So,
All right. So I think moving on next from schizophrenia, I think this is another interesting study that I came across, which was about ADHD. So, we've heard about ADHD before in the CME, and adult ADHD is something that we are increasingly coming across in clinical practice. A lot of patients themselves reaching out to us for an evaluation for ADHD. So this particular study was a long-term follow-up of around 480 children who were evaluated 9 times over a period of 16 years from childhood into adolescence and adulthood. So this was probably an interesting long-term prospective follow-up of ADHD. So why I found this interesting was that this study observed that up to 60% of patients actually have a fluctuating course, and remissions are common during adolescence. And a lot of the symptoms of ADHD are triggered by environmental demands. And also in this fluctuating group, they had a high comorbidity with anxiety disorders. And only 40% of them actually had a very stable course of ADHD. And these were the subgroup who had a higher incidence of mood disorders and substance use disorders. So the implication of this study is that uh, we typically understand ADHD as a neurodivergent condition, which we would expect to be stable throughout the course of its illness. Uh, but here this tells us that not everybody has a very stable course. Actually, ADHD symptoms can also be fluctuating. It can be very dependent on the environment and the stress that they are going through. So this needs to be kept in mind by clinicians when they are discussing diagnosis, prognosis, and long-term treatment in people with ADHD.
right. I mean, this is genuinely very interesting, even for a disorder like ADHD, where we feel like we do understand a lot of it. There are still so many more new things that we keep discovering. And I think this is a great reminder to all of us as clinicians that ADHD really isn't a one size fits all kind of a disorder.
That's right.
So this brings us to our final topic in our update, pharmacogenomics. Now, this has had a bit of a rocky ride, hasn't it? So this study is actually an update on the 2018 pharmacogenomics guidelines. So the 2018 guidelines did not recommend routine worldwide sort of use of the pharmacogenomic testing. In this updated review also, in depression, only 3 out of the 11 trials showed any significant efficacy. Plus, the study also dealt and targeted certain myths like pharmacogenomics are a one-time cost, they help reducing bias. We need to use pharmacogenomic tools for safe medicine. None of that is actually true. So all of these myths were also uh, debunked. So it's not really the sort of magic bullet that some people hoped for. And just exactly how the 2018 guidelines said, the 2024 study still does not recommend use of pharmacogenomics in routine clinical practice.
Right. Yeah, I mean, pharmacogenomics is something that is increasingly coming up, and it becomes sometimes dicey when you have a pharmacogenomics report, like in terms of, a lot of psychoeducation is then needed with patients to help them to understand, because the report itself gives you categories such as amber, orange, and green, and patients take it to mean that something which is in the red means that it should not be given to me. So
Yeah,
it sometimes becomes difficult. That's what the I think the third myth talks about, that it is prudent for defensive medicine, and sometimes it can expose clinicians to medical legal risks. Yeah, so I mean, I think there's still a long way to go in pharmacogenomics before it can be recommended in routine clinical practice. There may be some specific use case scenarios where it is useful, but not for general clinical use.
absolutely.
Right. So I think with this, we have come to the end of the topics that we had identified for you from our literature search of last year's papers, and what we found would be interesting and for clinical practice. So to summarize, I think we first started off with semaglutide, which has been increasingly being used for weight gain control and has wide applications, not only for treating psychotropic weight gain, also for Alzheimer's and alcohol use. And at the same time, there is increasing evidence that relatively semaglutide may be safe in terms of its neuropsychiatric side effects. And next, we saw about treatment of depression, and where we identified that there is a increasing evidence for role of RTMS early in the course of illness when there is an initial SSRI non-response. And plus 5 decades of psychotherapy research has still yet to come up with definite evidence for the use of, or for the effectiveness of CBT. Still, the quality of these studies still seem to be poor and with small effect sizes.
We also have new promising avenues in the management of both acute and maintenance treatment for acute psychosis and schizophrenia. So we have xanomeline, which is a new class of antipsychotics, non-D2 acting, targeting more the muscarinic receptors, and the paliperidone palmitate 6 monthly depot. Then we've also understood that ADHD can have a fluctuating remitting course even, and all of that sort of depends on the environmental demand. So we're still discovering new things about this disorder. And finally, we have yet again seen that pharmacogenomics still does not have enough evidence to recommend its routine clinical use.
Right. So thank you for joining us today in this recap of 2024. I hope the articles that we brought to you would be useful to you in your clinical practice and has given you some insights. We hope that 2025 would be a year where we see many more number of high quality research papers appearing with following good scientific methodology, and which will actually inform clinical practice. So thank you, Shalaka, for joining me and in presenting this. And so see you again in Recap 2025. And we would like to hear from you if there are any other studies that you have come across which you think are useful for clinical practice. And so do put in your comments in the comment box. Thank you.
Thank you.